Okay. Thank you, Stefan, and the organizing committee for inviting me to come here and talk about the Swedish experience of the Micropreemies. And thank you, Dr. Namba, for a very interesting talk. I'm Ulrika Ådén. I'm a neonatologist in Sweden, and I'm professor of neonatology at Karolinska and in Linköping. And all the data I will present here today are national population-based data from Sweden. First, we have the Express cohort, which is a control study with two different cohorts, 2004 to 7 and 2014 to 16. And that the continuation of that was really the neonatal registry, which now also includes data assessments from 2 and 5 years of age. And I'm also going to talk about patient registry data, also national and population-based. Okay, so in 2015, the Neonatal Swedish Society decided to do a follow-up program for all high-risk babies, neonatal high-risk babies, and also for the extremely preterm born, and that all babies should have several checkups during the first year of life, but then also structured and validated assessments at 2 years and 5 years, including psychology testing and physiotherapy testing. And we wanted to have all those results, or they are registered in the National Registry. And this is because, of course, we wanted to provide early support for each child and family and to make relevant referrals, but also we wanted to follow up how is Swedish neonatology doing over time. Because this is the goal, of course, that those small, tiny little babies will grow up and become healthy, happy, autonomic. And these are images from Nature when they did a popular scientific presentation of Swedish neonatology. And here's a baby boy born at 23 weeks in our unit at Karolinska. And what we do before birth, I think in all Swedish neonatal units, is that we have centralized care in 6 units in Sweden. So we prepare transport to a specialized center just before or at 22 weeks. And we provide, of course, antenatal steroids and tocolysis, and we provide prenatal consultations. And then at birth, we, of course, prepare the plastic bag and warm humidified gases, and we have a skilled team there. And we practice delayed cord clamping, of course, as you all do. And where I work, we take care of the baby inside the incubator, so we don't have to move the baby. And of course, we monitor everything, and often, in most cases, we intubate nasal if possible. In this case, it wasn't possible. And we start on room air, of course, and we give surfactant normally. And we give umbilical lines early on. And then we try to practice minimal handling after that. So we do as few ultrasounds as possible, and we treat blood pressure as little as possible, and so on. So minimally invasive. And families are a natural part, so they have a room in the unit, and both parents are on sick leave for the entire stay in the hospital. So we try to practice early skin-to-skin care also in the smallest babies within a few days, and parents are very much involved in the care of their children. And we all know that if you're born this early on, you have a very immature brain. And here's the baby brain from 12 weeks of fetal life to 40 weeks. So you are somewhere here. So all neurons are there. They have migrated to the right place in cortex, and they're just about to form cortical networks. And this process of cortical networks is very much dependent upon sensory input. And we all know that is a very unnatural thing to be in a NICU. So after that, these cortical networks are formed. There is apoptosis going on, there is myelination and all these things. So it's a very vulnerable time period of brain development. And I think that is reflected in these figures. So here we have plotted the whole Swedish population the last 50 years. And the risk for intellectual dysfunction, autism, and ADHD versus the gestational age at birth. And we see there's a linear relationship. So here there's 8 times higher risk for autism at 28 weeks than at 40 weeks. And it is linear also that 22 weeks is 20 times higher. For intellectual dysfunction. For autism, the risk is 4.5 times at 22 weeks, and for ADHD, 2.5 times. And these conditions are generally thought as very hereditary. So in this case, we have a family-based design, so we can adjust for having a first-grade relative with the same diagnosis. So when adjusting for that, we see absolutely nothing happens. So this risk seems to be very much related to the biological risk of being born preterm. And every week less that you are born constitutes a higher risk for intellectual dysfunction, autism, and ADHD. So this relates very much to the previous talk by Elaine Boyle as well for the late preterms. So when it comes to survival rates, in all high-income settings, I think there has been a great success in increasing survival rates of extremely preterm born children. And here we have the 22-weekers in Sweden from 2004 to 7, and then around 20%, because we had 2 centers out of 6 who were active. And then at 2015-16, we had a little more than 50% survival rates. And what happened in between there was that we got a Swedish consensus guideline in 2016 saying that we recommend transport in utero from 22 plus 0. We recommend to consider antenatal steroids from 22 and recommend it from 23. And we consider C-section on fetal indication from 23 weeks. But I think the most important thing here was that we decided that there should be a neonatologist present from 22 plus 0, because we all know it's difficult to be there and not to do anything. And to consider CPR from 22, and it's recommended from 23 weeks. So what happened then after this guideline? Well, as I mentioned, at 2014 to 2016, there were a survival rate like 55–60%. But then at 2017 to 2019, it was just below 50%. So it's quite stable around 50% on a national population-based level in Sweden. So we're not improving at the moment, the last 10 years. And then for 23 weekers, it's between 65 and 70. And these data are published in JAMA Network Open. Then, if we exclude all the ones with severe neonatal morbidity, so severe IVH, BPD, ROP, NEC, we see that we have 20% of the 22 weekers have survived without severe neonatal morbidities, and about the same, maybe 25% of the 23 weekers. And then it goes up with higher gestational age. And then when it comes to long-term outcomes, as we've heard here today, we often measure neurodevelopmental impairment in order to compare different cohorts. And neurodevelopmental impairment is just based on the normal distribution. So everything above -1 standard deviation is regarded as a normal outcome. And between -1 and -2 standard deviations is a mild outcome, and below 2 to 3 standard deviations is a moderate outcome, and below 3 is a severe outcome. And you can categorize, Bailey testing for cognition, language, and motor function, or WIPSI testing for cognition in this way, and also CP and hearing and vision. And I think a major drawback here is that this classification does not include autism and ADHD, which seem to be a very common problem for the smallest babies. So using the NDI classification then, this is a publication from Japan, comparing outcomes in the US, in Japan and Sweden. And I just wanted to draw your attention to the different denominators here. You can have, you can look at results out of live births, or out of actively cared for, or out of assessed survivors that came to assessment. And here, and this is a Japanese cohort from 2008 to 12, and the NICHD network from the same years, and the Swedish Express cohort from 2004 to 7. And we see that there was clearly lower rates of deaths in Japan than in the US and in Sweden. I think it's because we did not provide as much active care. But then if you looked at the survivors that came to assessment, it's strikingly similar. And here we have 22 weekers, 23 and 24 weekers, that it's about half-half. So half of the children that survived and were assessed had no to mild NDI, and half of them had moderate to severe. So it's not a clear relation between survival rates and outcomes in the long term. Here are some more recent data from Sweden and not published yet. It's the second Express cohort between 2014 and 16. And here, if we look at the survivors who came to assessment at 2 years, we have like half of them with a mild to moderate, no to mild NDI, and half of them with a moderate to severe NDI, both at 22 and 23 weeks. And then the good outcomes increase with gestational age and the bad outcomes decrease. When you look at the denominator out of actively treated, because all of them were actively treated at that time, we have about 25–30% with no to mild NDI, and the rest with death or moderate to severe NDI. Pretty similar in 22 and 23 weekers. Here are 6 years outcomes from the first Express study, 2004 to 7. And here we had no children with a normal range outcome at 22 weeks. We had a few in the 23 weekers, but the majority had mild, moderate, or severe outcomes at 22 and 23 weeks. And if you look at out of all live births with a known outcome, there were like a vast majority, 95%, who died or had a severe NDI at 22 weeks, and around 65% at 23 weeks. Here are 12 years outcome in the same Express 1 cohort, and they are pretty similar. That's good because I think we get pretty good data from 6 years outcome, and this is still in manuscript, but the previous one was published in JAMA Pediatrics. And if we look at out of assessed children, still at 12 years, we don't have any within the normal range, born at 22 weeks. We have a few of the 23 weekers, but most of them have mild, moderate, and severe outcomes. And out of all live births, it's the same figures as at 6 years. So a vast majority had a severe disability or death at 22 weeks, and 65% at 23 weeks. What is not included then in the NDI classification is autism and ADHD. And as I mentioned in the beginning, it's really 20 times higher risk for intellectual dysfunction, but like 3–4 times higher risk for autism and ADHD at 22 weeks compared with 40 weeks. So here's the whole group of 22 to 26 weekers in Express, and we see that in the group that has moderate to severe outcomes, we have around 25 and 30% autism and ADHD. In those with no NDI, the rates of autism and ADHD are like 5 to 10%. We also administered the child behavior checklist for behaviors could see what has been seen in many previous studies, that there are lots of problems with internalizing behavior at 12 years of age, meaning that they are anxious, they have emotional problems, they have fewer peer relations, and they are bullied. So here you see 35% have internalizing problems, and out of all groups, we have around 30%. So now I wanted to tell you about another study population from Sweden. And here we have gathered all the babies that were born and survived at 22 and 23 weeks. And they are altogether 399 children. And this has been published last year, 2 years ago. And we see out that 78% had any neurodevelopmental disorder. About 50% of the 22-weekers had intellectual disability, a little less in the 23-weekers. Around 30% had autism, around 25-30% had ADHD, but almost half, or a little more than half, had speech disorders. And there was one difference between 22-weekers and 23-weekers. More of the 22-weekers were in habilitation services, and they also had a higher rate of intellectual dysfunction. When it comes to somatic problems in the 22 and 23-weekers surviving in Sweden, we see that most of them had a somatic diagnosis, 87%. And not surprising, like 60% had asthma, and about 50% had failure to thrive. But I was more surprised to see that 70% had gastrostomy, 19% in the 23-weekers. Also, like 14% had vocal cord paresis, and 12% had respiratory impairment, meaning that they had respiratory support at home, like CPAP at night and so on. So they were very sick, and almost all children of the 22-23 weekers had either a neurodevelopmental disorder or a somatic disease. And here we had different ages at when we looked up the diagnosis, and we could see that it's not only a delay that disappears with time, but you get more and more of these diagnoses with time. So I think we know very much about this group of babies in Sweden, how they do and what they need. And I think that we are constantly thinking that this will improve with time if we get a little better at making them survive, if we adjust if we adjust all these small things that we do early on in the NICU care, maybe we can get some better outcomes. I'm not so convinced about that, but here are some data. Here is data from extremely preterm and very preterm born children, and a meta-analysis from Twilher, and looking over a number of different cohorts since the 90s. And what we can see is that the cognitive performance is around -1 standard deviation, and it's pretty much stable over decades. And there are some more meta-analyses, but I'll show you the latest one by Kirpalani's group, again showing that, and here he looked it up into different age groups, so in the 22-23 weekers also, there is really no significant improvement in your developmental outcomes over time, over decades, in this group, including all the national cohorts that have been that are of importance here. And these are some unpublished data from us in Sweden, where I cut out the 22 and 23 weekers, and we see that we have about the same 2-year outcomes in the 2 Swedish express national cohorts at 22 and 23 weeks. So about 50% no or mild and 50% moderate to severe. And actually for 24 to 26 weekers, I didn't show that here, we actually have a worsened outcome in the later cohort, and we need to understand why that is. So how do we reach the goal of having healthy, happy young adults growing up after this very complicated start? Are we doing good or harm when providing active care to the smallest infants? We know that we have a very high, when we decide to give active care, we know that we have a very high risk of either death or severe NDI, and a very low chance of a normal or mild outcome. I think we tend to say that we don't know what will be the outcome of this child, and for true, we never know on the individual level, but on a group level, I think we know a lot. We know that if we provide active care, we can improve survival rates a lot, and we can get about 50% on a national level in Sweden. We can come to, in a single center in Japan or maybe in Sweden, we can get up to 80% survival perhaps. But it seems like in the survivors presenting for assessment at follow-up, almost all of those smallest babies have special needs. Either somatic or neurodevelopmental impairments in 75% of them. And these outcomes have not improved over decades. So my take on this is, if we decide to provide active care, we really need to provide structured follow-up, early interventions during childhood, and there are now some interventions which are evidence-based, for example, for CP, and also for some earlier for autism. And we also need to arrange a societal support for these families. And finally, this is from John Lantus, Just Because We Can, Should We? And here is the Tiny Babies collaboration, stating that there are a number of considerations to take into account if you offer care for the smallest babies. And I think a very important part of that is to have a decision making with the parents and an ongoing communication with the parents. And with that, I'd like to thank you for your attention.